The Confidence Doc podcast is brought to you by My Evergreen Med Spa. Located in Houston in the Woodlands, My Evergreen Med Spa brings to you the latest aesthetic treatments in the most luxurious environment. Remember, My Evergreen Med Spa, it's me time elevated. Welcome to the Confidence Doc podcast. I'm Dr. Rednam. I'm a board-certified plastic surgeon in Houston, Texas with my Houston surgeons. And for today's episode, we have Dr. Ahmed Nasser on. Welcome to the show.
Thank you so much. I'm honored to be here.
Dr. Nasser is a board-certified plastic surgeon. And where do you practice?
So I practice out of New Jersey with offices in both Red Bank and Brick.
And he has a very unique plastic surgery practice that we are going to talk about because not all plastic surgeons do all the same things. But I want to know, how did you become a plastic surgeon?
Yeah, I owe a lot of that to my father. So he's a plastic surgeon as well. And one of my first exposures was when I was around 14 or 15 in high school. And my father had a poor patient who came in with an amputated forearm from a boat factory accident. And he was replanting his arm and he wanted to take a video clip of it. And I went in and actually helped film part of that in the operating room. And that was probably the bug that bit me early on, and I just never looked back.
I love it. It's the family business. So,
You could say so.
but that's amazing. Not many people get to have an exposure to plastic surgery that early. So that's amazing that you got to have that.
Yes, I mean, I'm grateful for him and my mom in so many ways. But yes, he was and still is a role model. He's still a practicing plastic surgeon, and I actually call him almost every other day for advice about operations and things. And it's just it's so awesome to have that kind of relationship with him also.
Have the two of you ever operated together?
Yes, I did when I was a resident. I did an away rotation. Actually, I think I was a medical student. I did an away rotation, and we were able to operate together. And it was one of the best things ever.
That's so cool. I love that. I look at my kids sometimes and like, maybe one of you will operate with me one day.
Only if they want it. Only if they want it.
So what was the pathway that you took to plastic surgery? So you obviously had the interest very early on.
Yes.
Did you do a traditional path? Were you an integrated resident?
I did do a hybrid of both. I did the traditional pathway. I did a full general surgery residency. And then after that, actually, I did a year of burn fellowship at Nassau County in Long Island. And the same folks, the Long Island Plastic Surgery Group in Stony Brook, who run that burn unit, also were starting an integrated plastic surgery residency. And we got it on, and they took me in as their first integrated resident. So I basically backfilled the 4, 5, 6,
Very
years because
cool.
they had no seniors yet.
You really were a hybrid. That's really
I was
interesting.
it was really hybrid, exactly, somewhere in between.
And then when you finished, what did you start off doing? What kind of surgeries were you doing in plastics?
Yeah, there was another year after that where I did a year of sort of you could call it a super fellowship in breast reconstruction and also migraine surgery. This was at the Mass General Hospital in Boston. And I want to give a shout out to Dr. Austin, who's amazing. He's one of my mentors and the guy who taught me migraine surgery. And that actually changed my career quite a bit because I was actually headed to craniofacial fellowship after plastics, and I had the programs all lined up. I had my list, the program directors, contacts, everything. And then I met him in one of the grand rounds that he gave us, and totally changed my outlook. And I ended up, doing the fellowship with him, and now migraine surgery is one of the main things that I do in my practice. So yeah.
And I think that's something that a lot of people don't know that a plastic surgeon does. So,
Yes.
can you explain a little bit about what migraine, like who's a candidate for migraine surgery, and like how do you actually treat migraine surgically?
Yes, and I'll just start with a small anecdote because the first time that I heard Dr. Austin speak to us, I didn't know anything about migraine surgery whatsoever, and I was your typical, chief resident at the time, about to graduate. I have my mind set up, so here's another person talking to us about something I'm not interested in. I'm sitting in the back, not paying attention. But then he is so charismatic, and then eventually we got to talking. Basically, it's occipital neuralgia, which acts as a trigger for migraine surgery, for migraine attacks or headaches. And what we do is similar to what a lot of plastic surgeons do with peripheral nerves everywhere, like carpal tunnel, like tarsal tunnel, like pudendal neuralgia, is decompress the nerve. So, you have the pair of nerves in the back of the head, greater occipitals, lesser occipitals on the outside. And these nerves can get compressed due to one of many reasons, and scar tissue, previous trauma, previous surgery, and because of that they can actually act as a trigger for migraines. And unfortunately a lot of people, including doctors and even plastic surgeons, just don't know about this. So I'm always trying to get the word out.
Well, so because like you said, like not a lot of people know that that's the trigger for it. How do you know that you may be a good candidate for the surgical release?
That's a great question. So I think it starts with just identifying that that's actually the problem. So the diagnosis, that's the biggest obstacle because a lot of patients, I mean, 3% of all ER visits annually are headache related. And so that's a number in the millions. And of those, some studies have shown a quarter of those can be occipital neuralgia. So typically it's pain that starts in the back of the head and radiates both upwards and to the side. And, we always want the patient to be evaluated by a neurologist, make sure that there's nothing else going on, have the appropriate imaging, whether it's CT or MRI. And then eventually we'll do a nerve block right on the greater occipital or lesser occipital. And if they respond well, that usually means that this is actually what it is, and that's the nerve involved. And, some people choose to get Botox, which is a temporary relief for that. Some people take muscle relaxants, some other migraine medications. But if someone's a good candidate for this, then the surgical release can be a permanent solution for that.
Which is just amazing. That could be a very life-changing surgery for somebody.
Absolutely. I mean, I've seen CEOs of companies, people who are very highly functional people, literally get reduced to nothing or like go into disability because of how debilitated they are from this. Some people, frankly, become suicidal because of this. Because, I mean, the descriptions you see of this pain range from burning to aching
Mm-hmm.
to ice pick in the back of my head.
Gosh.
It's the kind of stuff that nobody wishes on anything on anyone else.
Is there a time limit? So if you've been suffering for years from this versus decades, like is there a time where the surgery may not be as beneficial?
That's a great question, also, because we have shown that there are certain instances where you go in to release the nerve and decompress it, but the damage is far gone. It's been compressed for way too long. And sometimes we actually have to cut the nerve, in which case the patient then becomes numb in the back of the head. 99.9% of the time, we try not to do that on the first surgery, the index surgery. But then if they recur, as we always try to decompress it, if they recur, then we come back and we'll offer them an actual transection and rerouting of the nerve. But there are certain instances, for example, patients who have gotten radiofrequency ablation, where studies have shown that decompression becomes less likely to succeed after RFA, and they'll end up needing the nerve to actually be cut.
Okay. But it's good to know that there, even though it may be a more extreme option, that there still potentially is something, even if you fail the traditional release.
Absolutely, absolutely. And if you ask 9 out of 10 chronic pain patients with severe migraines from that, they'll tell you they'd rather be numb rather than have, that ice pick in the back of their head any day of the week.
So I got it next is a two-part question for you because I'm sure there's somebody listening right now is like, this sounds amazing. Is my insurance going to cover it? And if they
Yeah.
do cover it, what criteria do they have to meet in order for insurance to cover it?
Yeah, I think it's probably right now a 50-50 bag. A lot of insurances do cover it, and it may mean that we need to do a peer-to-peer, or we need to send a letter of medical necessity, which is completely fine, and we have a whole team dedicated to that, and discussing and getting the approvals from insurance companies. Unfortunately, there's still some insurance companies that will call this experimental, which it really is not. This is not experimental surgery. I mean, the grandfather of the surgery is Dr. Guyron, who is like one of the big people in our field, as you know. And he's been doing this surgery for over, I would say, 15 years, probably more. So this is not experimental. It's been heavily researched. It's been shown to be highly effective. So I would say in most cases we're able to get in with the insurance company and explain our viewpoint, and get them approved.
Yeah, it's a shame considering nerve release in itself has been going, like you said, all over the body. The concept is not new at all,
At
nor
all.
really is the surgery. Are there other nerves in that are like other cranial or skull based nerves that like you have to do releases as well, or is the occipital nerve the most
It's so
common?
there's yeah, the two graders, and then the two lessers run more, as you know, behind the ears and into the temple. So sometimes we have to release those as well. There is a third occipital, which is usually in the center, but usually that's not a main culprit. So it's usually the two graders and two lessers. Now, a lot of headache patients in general that have triggers in the back of their head also have other branches of cranial nerve 5, such as the auriculotemporal, that may be involved. So if they have pinpoint pain right where, the branch of the superficial temporal artery, then we can actually go in, and we usually end up not releasing it, but cutting the auriculotemporal nerve. And that usually solves the problem. So if their pain starts there, or the supratrochlear and the supraorbital is another common one.
Yeah. Are there a lot? Do you feel that most neurologists are very aware of these surgeries? Because, you're saying like you'd see a neurologist, and I'm just
Yeah.
curious, like, how aware that the neurology community is about the benefits of these surgeries.
I think thanks to people like Dr. Austin, who have been fighting for this for such a long time. One of the close neurologists that he has worked with over the years is Dr. Paul Matthew, who's well known in the neurology side of things. And in the beginning, I think the idea was still that this is maybe experimental surgery. This is not the standard of care. But Dr. Austin kept operating on literally hundreds of these patients and sending them back to the referring neurologist. And now I think he's one of the biggest referral sources to him. So, and then now there's more and more publications in the neurology literature showing the efficacy. And of course, we have several in our own. So I think, a lot of neurologists are more on board with it, lately. But, I still feel like the word needs to get out both to them and to our own folks.
Because I would assume that you probably get people from all over because it is very specialized, still
Yes.
within our field.
Yes, absolutely. Absolutely. A lot of out-of-state patients, some, even international that just hear about you. So, one of the things that I've been trying to do, and we connected recently in one of our conferences, is to spread the word through TikTok, and and the feedback has been enormous. I mean, I did not know that the feedback was going to be like this. People reaching out, and a lot of chronic pain patients who are just at their wits' end with headaches or trigeminal neuralgia or occipital and others that were just reaching out nonstop.
And you're in a unique position because you're a reconstructive surgeon, right? There's a lot of cosmetic surgeons that are
Yes.
on the social media and things, and so for you, this was something that's a little. You had to kind of make your own pathway there because there's not as many people doing this. But it sounds like it's really worked out well.
Absolutely. Again, I know I'm preaching to the choir, but you're a trailblazer, a blazer in the field yourself. But I think TikTok for a while and social media for a reconstructive surgeon was like, a bad word. Like you don't say that, you don't mention that. It's
Like
just
we don't
for
do
the
that stuff.
yeah, we don't do
Yeah.
that stuff. We're higher than that. And that's unfortunate because really, from referrals to just asking questions to
Hmm.
spreading the word, it's been enormous. And I love doing it much like you do. So I'm going to keep doing it. And if it aligns with, what I'm trying to educate about and spread the word, then it's great.
Well, and if you think about it, between TikTok, even YouTube, I mean, the reach you have is worldwide.
Absolutely.
And there very well could just be somebody who's putting in some of these terms that nobody else is talking about but you.
Yes.
And so
Yes.
it's amazing to be able to connect with your patients and wherever they are.
Absolutely. And it's instant, as you know. Like they're not going through front desk personnel or
Yeah.
this person or that person. And they love that. I mean, I've had several people be like, "Oh, this you're the first doctor that I've spoken to directly about this." You know, it's that sort of instant feedback, and they love that.
Yeah. And I think it's different too, right? I think that, like, you're not trying to sell products. You're really
Absolutely.
just
Yeah.
out there trying to educate.
Yeah. Yeah, absolutely. And a lot of times, even if we end up connecting through like a virtual consultation, I always make it a point to tell them exactly that. We're not selling a product. I'm not selling you surgery. We're just trying to see if this is something that you can benefit from, if you're that debilitated by this.
Yeah, and I've had this conversation with a lot of different plastic surgeons, both cosmetic and reconstructive, and at the end of the day, social media is the new website. This is the way that
Yes.
we can connect with people, and they get to know you, right? They're like, "Gosh, he's a nice guy. Like he's going to take care of me," and so it helps us build this really nice relationship with our future patients.
I mean, absolutely. I mean, we connected briefly in the conference. It was our first, but I was spying on your Instagram, and I saw some of those 5:30 a.m. get ready with me videos, and
Yeah,
I can relate to that because I've been trying to be better about going to the gym and
yeah.
just waking up super early, and that 5:30 a.m. wake up is rough. It's just
it,
like, on
I
the
know.
days where
I always laugh. I'm like, I picked the wrong specialty for not being a morning
I'm not a
person.
morning person. I know you're not. I'm not a morning person. I need that coffee. So like I'm
I
running
know.
to my espresso machine and then to the gym kind of like half awake. But to your point, I've had so many patients come to the office and they're like, I feel like I've met you because what I'm trying to do with my own, for example, Instagram is I'm just trying to show them a snippet of who I am as a person. So there's some stuff that is personal to me, obviously being careful to still protect my family and their
Yeah, of
privacy.
course.
But at the same time, just, hey, I'm another human being. I have issues too. I have some good days, some bad days. This is what I do. This is how I operate. This is my staff. So by the time they actually get to the office, they're like, we feel like we've met you. You're a real person.
And I think that's important because unfortunately, certain things, medicine and surgery, people feel like they dehumanize us. They don't think,
Yes.
and we do care. We all went into this because we care. And,
Yes.
I think the hope is that we can repair that relationship so that people see that their doctors are people who care about them and that we can be trusted.
Exactly. And then, there's that old style of like, I'm going to sit in front of a video and lecture you about what I specialize in. I'm here and you're here and
Yeah.
you're going to listen to and I really, I hate that. All due respect to everybody in our field, but I don't like that. Like I want my patient to feel like they can relate to who I am.
Yeah. I agree. I agree. Obviously, we connected on that
Yes.
sentiment very much so. What are some things you're really excited for in your personal practice? Like things that you like or new technologies that you're excited about in your area?
Yeah, I mean, there's actually related to occipital neuralgia. There's some new imaging techniques, including like special forms of like MRI neurography that may be able to actually help us with diagnosing, the compression even beforehand. Because right now, none of the imaging is actually accurate enough to say, like, ultrasound, which has been around forever, but they're all subjective, and you can't really say, oh well, this is a compression right there, and that's what's causing that. So there is some of that coming around. Other than that, honestly, I'm excited by some like really bread and butter things too. I mean, I have the highly specialized part.
Yeah.
I love doing a great breast reduction or a great tummy tuck. Honestly, those are the some of the most transformative things like in my practice. I had a 16-year-old, which was one of like the younger people that I did, very large breasted, was being picked on at school, was about to get into like, junior prom, was like 6 months away, whatever. We did a breast reduction. She couldn't be happier. And she went to junior prom and, sort of a more traditional looking dress that she wanted to fit in, and you know, to me, I'm always going to keep that as part of my practice because I love the specialized nerve stuff, but I also like, transformative. I like, changing someone's life through a very straightforward bread and butter surgery that we do.
And I think that's why I think we really are general surgeons in
Yeah.
plastics. We take care of everything. And, I've had people say that to me about, they're like, oh, you have a really busy cosmetic practice. Like, are you done with insurance? I'm like, I love breast recon. Like, I
Yep.
mean, I
Yep.
like doing
Yep.
micro. I like these things. And so it's like, it's not a matter of I'm doing this to get rid of that. It's like, I think a lot of us picked our specialty because we
Yep.
like doing lots of things.
Yep, absolutely. The breadth of what we do, and I talk about that sometimes even to patients and friends. I love that. Like I still do a fair amount of abdominal wall reconstruction, some breast reconstruction. I do a fair amount of like Mohs reconstruction for the face.
Is there
So,
anything that you don't do that you're just not as fond of,
um,
or?
I don't, it's not that I'm not fond of it. I don't do micro in my own practice. I will
Mhm.
help my colleagues every once in a while, like do a micro case, but I don't do, free flaps myself. But that's about it, and maybe creating facial, which is funny because that's what I thought I was going to go
That's
into. But, and I love
well,
working with kids. I love working with kids, but, those are probably the only two things that are not like big parts. And we have so many also amazing hand surgeons in our practice. I don't really do hand anymore. But other than that, like, it's pretty wide.
yeah, and I've stayed that way too. I don't do rhinoplasty, just
Same.
because we've got people just
Same.
they would do that every single case,
Yes,
and I think that it's such an interesting surgery and requires such
absolutely.
skill, but it's not for me. So
Yeah, I always say, rhinoplasty, you're either eating, dreaming, living it every single day, and that's what you do all day long, every day. And those are the people that should be doing it. And I know several sort of my mentors in training who that's all they do, and the great. And that's who should do them. Like, I don't think you can dabble in it.
I agree. I agree.
Yeah,
And it sounds like you're doing amazing things and making people's lives a lot better.
I
So
appreciate
with
it. No, you
everything you're
you
doing.
yourself too.
If somebody was really, they're like, man, this sounds great. I'm interested. I want to seek you out. What's the best way for them to find you?
Yeah, absolutely. Either directly through social media, also, our office number, our main office number, and getting them right through into like our coordinators. We're always happy to return to them as quickly as possible.
And what's your handle?
Yeah, so on Instagram, it's Nasser Plastic Surgery, and on TikTok, it's I believe it's Ahmed Nasser MD.
He's like, I believe it.
I forget that one.
We
You
will
can
definitely
edit it
we
in
will
post, edit
we
that
will
one in
def
post.
no,
But
it's cute. It's
yeah,
funny. I'm leaving.
on Instagram, it's Nasser Plastic Surgery.
And we will definitely have that below in our comments so you can check him out and the amazing work he does.
I
But thank you
appreciate it.
so much for being on
Thank
the
you.
podcast. You educated us in something new, and I hope people realize like plastic surgery, I'm biased, is like one of the coolest specialties. We have our hands in everything because we're all about form and function, and I think we all just love it. So.
Absolutely. Thank you for having me, first of all, and your team also behind the scenes have been like super gracious. I know we're going to be friends for a long time, and I know we're going to
Absolutely.
be social media buddies. So I really appreciate it. And you might be. Did you say you're 5'1"?
Say it again.
Are you in your videos? Do you say
Oh,
you're
I
5'1"?
wish. I wish I was 5'1". I'm 5 feet tall.
Okay. However, you project yourself way taller than that, is what I wanted to say. You
Thank you.
project yourself way. Yeah, exactly.
I patients actually say it all the time. Like they'll come in and they're like, "I thought you would be taller." I'm like, "I
No,
don't
no.
care. I don't carry myself short." So,
No, you carry yourself very tall, and good for you. You've done
well, thank
amazing.
you. Well, and thank you all for joining us on this episode of the Confidence Doc. I don't have to say I hope you learned something. I know you learned something this time. And join us again for our next exciting episode.